Good morning, everyone. I'm Kayhan Parsi, and I'm an associate editor for the American Journal of Bioethics and a professor of bioethics at the Neiswanger Institute for Bioethics at Loyola University Chicago Stritch School of Medicine. I want to welcome you all to today's AJOB webinar. The title of today's webinar is Structural Racism in the COVID-19 Pandemic. We're fortunate to have an amazing panel to discuss today's topic. AJOB and bioethics.net are dedicated to exploring a variety of issues in the field of bioethics. Today's panel discussion will build upon the AJOB target article, Structural Racism in the COVID-19 Pandemic, moving forward. The recording will be posted on AJOB's YouTube page. Now I'd like to introduce our panelists. First, we have Dr. Maya Sabatello, LLB, PhD, an associate professor of medical sciences at Columbia University Center for Precision Medicine and Genomics and the Division of Ethics. A trans-disciplinary scholar encompassing law, political science, and bioethics. She specializes in research ethics and genomics, disability justice and health disparities, and human rights law. Her work centers around societal inclusion of and health equity for marginalized communities. Next, we have Dr. Georges Benjamin, MD, known as one of the nation's most influential physician leaders because he speaks passionately and eloquently about the health issues having the most impact on our nation today. From his first-hand experience as a physician, he knows what happens when preventive care is not available, when a healthy choice is not the easy choice. As executive director of APHA since 2002, he is leading the association's push to make America the healthiest nation in one. And then finally, Professor Ruqaiijah Yearby, JD, MPH, Professor of Law and Executive Director of the Institute for Healing Justice and Equity at St. Louis University. She specializes in racial health disparities in healthcare, the political economy of healthcare, and social justice in medical research. She's dedicated her career to improving the lives of vulnerable populations by addressing the lack of equal access to quality healthcare. So each of our panelists will speak for roughly 10 minutes or so, and then we'll open it up to your questions. Please post your questions in the Q&A. And so we'll start with Dr. Sabatello.
Thank you very much, Kayhan, and for AJOB for organizing this webinar. It's such a great honor to be part of this. I want to first of all acknowledge my co-authors on the target article, Mary Jackson Scroggins, Greta Gatto, Alicia Santiago, Alma McCormick, Kimberly Jacoby Morris, Christina Dalton, Carla Easter, and Gwen Darian. This article could have not been without this collaboration. Our target article was developed alongside the emergence of data about COVID-19 morbidity and mortality. And initially, the data was only about the disproportionately high impact of COVID-19 on Black and African Americans, and a little bit about Latinos communities. But over the next few months, since we started, which was in April, data continued to pile up, highlighting the disproportionate impact of the pandemic, also among indigenous populations, and more recently, and well after our paper submission, about subgroups within the Asian American community, such as the Filipino nurses. And the numbers keep piling up. As we all know, or if you looked at the latest number as of March 24th, of the about 500,000, just over 500,000 recorded COVID-19 deaths, almost 100,000 of them are Hispanic, almost 80,000 of them are non-Hispanic Black, and over 6,000 of deaths are of members of indigenous communities. And these are just the deaths, not infection rates, which are higher. And these numbers also do not account for those whose COVID-19 death was not recorded in the death certificates, and those whose race or ethnicity has not been properly reported or misclassified. A systemic issue that we have, for example, with regards to indigenous populations, as well as with Asians, including Native Hawaiian and Pacific Islanders, where their numbers are still pretty murky. Now, the pandemic is only the tipping point of racial and ethnic-based health segregation in this country. As we know, the United States is the only Western democratic country in the world that does not provide universal access to healthcare, that has structurally organized its healthcare sector as a business initiative, one that views healthcare as a service, benefit, and white privilege, not as a basic right, and that has historically built up by the powerful few, and that is also maintained and resists changes by the privileged few. And we have decades of research documenting the disproportionate burden of this healthcare system on racial and ethnic minorities. Black, African Americans, indigenous populations, many within the Latinx community, and subgroups of individuals from Asian ancestry are less likely than white to have private and comprehensive health insurance, even as they are full-time employees. They are less likely to have access to routine preventative and therapeutic care, which leads to disproportionate high prevalence of disability and poor health outcomes. And they are more likely to experience biases when seeking clinical care. And that comes down to issues from lack of knowledge due to deprioritization of health needs of communities of color, to medical classifications that are still determined by the standard of the white normal-bodied male, and to outright misinformation about racial-based biological differences. Moreover, when we discuss, as we discuss in our article, and of course it's supported by extensive research, there are other inequitable structures in our society that interact with one another and impact the COVID-19 outcomes among communities of color. Wealthism, which was built on the history of slavery, displacement, and colonization, deprived people of color of generational wealth. Limited educational opportunities and overrepresentation of communities of color in many of our frontline and essential worker sectors disproportionately expose such workers to the COVID-19 virus. Financial arrangements that make it harder for people of color to own property have resulted in overcrowded living arrangements and enabled the COVID-19 virus to travel quickly into multi-generational homes and poorer neighborhoods. And we have over-incarceration, lethal policing of communities of color, as has been so crystal clear with the killing of Breonna Taylor in March, George Floyd in May, and many others before them and since then. And as the number of the COVID-19 morbidity and mortality among people of colors kept piling up, the feeling that started creeping in was that we're in the midst of some sort of perhaps a new type of politicide, the mass deaths of sociopolitical communities due to structural racism. So it is within this context that we proposed in our target article to establish a Truth and Reconciliation Commission in the United States. Now, when we're used to thinking about TRCs or Truth and Reconciliation Commissions in the context of developing nations, and it seems to be a contradiction or a contradictory image to the established democracy that we have. And it is true that historically, Truth and Reconciliation Commissions have emerged in countries coming out of totalitarian regimes, such as South Africa, apartheid, Rwanda. They have generally focused on government-led systemic human rights abuses, torture, disappearance, and arbitrary execution of citizens. But investment in human security and development is the bedrock of modern democracies. And although a focus on health and health outcomes, as we suggest in our article, may seem to be a little bit on a different par with historical instances of Truth and Reconciliation Commissions, health is indivisible from other well-established civil and political rights that are core to the nation's existence, from the right to acquire and own property to the right to equality and due process and the right to life. And our proposal for TRC has been informed by social sciences scholars who study genocide and its aftermaths, highlighting the cycle of incitement, scapegoating, and violence leading to atrocities, which we have also seen with growing attacks against Asian communities since the beginning of the pandemic, the role of bystanders who can intervene to stop the cycle of violence, and the harms caused primarily to victims, but also to perpetrators and bystanders who adjust themselves to the events. And as Eleanor Bright Fleming, a descendant of enslaved families, strongly expressed, the harm to America as a collective of people, a nation that professes the democratic ideals of dignity and equality, but has denied them to the very citizens who built it. So in this context, a TRC provides hope, and it is forward-looking. Truth and Reconciliation Commissions offer an opportunity to engage with the past through a formalized process that involves all stakeholders. And they aim at achieving national healing, creating a socio-political structure that is conducive to promoting equality and human flourishing for all. So what would the establishment of a TRC in the United States entail? We envisioned a national federally funded commission comprising racial and ethnic diversity and expertise across relevant disciplines. In our article, we've highlighted healthcare providers and healthcare managers who are undoubtedly key actors in our healthcare system, as well as expertise from below, community members working on the ground and can come up with explanations of what are the experiences and the needs. But of course, the commission should also include a range of other expertise, such as law, human rights, bioethics, social scientists working on social justice and structural isms who can inform the process. And as in other Truth and Reconciliation commissions, we suggested that the commission should have a process in place to hear and document in public records the voices of those who experience oppression in healthcare and its intersections, as well as clear processes to acknowledge and to take responsibility for historical and contemporary wrongs. More specifically, when thinking about what the issues that the TRC should be tasked with, we have three overarching issues. One is a basic right to healthcare and health equity, including access to care, coverage and costs, revisiting medical classifications, risk assessments, and treatment recommendations that have biased the care for people of color, as well as rethinking the role of racial and ethnic categories and how they should be defined and utilized in medicine and biomedical research. Ultimately, the goal is to create a racially and ethnically equitable healthcare system in terms of who gets access to quality care, but without ignoring the lived experiences of communities. And there's actually quite interesting process now in place with some medical disciplines that are really doing that, looking into how they define different conditions and what are the criteria for determining treatment and what types of treatment. And this is, that's been very upfront, for example, in the context of nephrology. And it's really encouraging to see these efforts. But I think there's much room for those efforts to be made across medical disciplines and done with transparency regarding what we've done wrong and how we're moving forward. The second thing that the Truth and Reconciliation Commission should focus on is the indivisibility of rights and intersectionalities. As we all know, individual and community health is indivisible from other arenas, such as educational opportunities, employment conditions, and socioeconomic status. Racial and ethnic communities are also heterogeneous, and the lived experiences of members from the same racial and ethnic category are not unidimensional, but complex. We have disability status, gender, and cultural differences that are key to the aspects of the human experience, and they are too greatly connected with inequitable structures that result in poorer health outcomes. So the TRC should explore and assess where systemic biases and racism kick in each of our societal and economic structures. And third, the TRC, and I think that's actually the most important part, is that the TRC really needs to be empowered to come up with an actionable plan to implement the vision of equity and equality as promised under the social contract of democracy. Workforce diversification across the board, medicine, research, banking, education, assuring processes for inclusion, cultural competency, and ongoing self-reflection as to where we're going, where we are, and what we can improve. Rethinking how our data collection and analysis can account for the heterogeneity of populations and complexities of their intersectionalities. And that's been suggested also by a few of the commentators on our target article, and we're really grateful for that. And finally, reparations. There's a growing discussion about it, and scholars have started to think how reparations could be implemented, and there are national and international examples that can support that. Again, there's growing literature also here in the United States now, whether it should be COVID-19 specific, about the history, how to move forward. But I think here we need to really hear the community voices and hear what would be most helpful for them, with the understanding that reparations do not rectify the harm and pain or restore the lost dignity. These are issues that monetary awards cannot buy, but that the reparations provide a form of acknowledgement of injustice and a redress, enabling communities of color to move forward with respect and dignity. Now, there are quite a bunch of more local projects that are intended to explore some of these issues. And again, I think this is really great to see some movement around this issue now with such intention. I do think that having a national process offers a more comprehensive and unified approach, and therefore can have longer term and greater success. So just to conclude, a TRC is not a quick, easy to implement process. It takes time, it's complex, it is emotionally tasking for all involved, and it requires strong leadership with a vision of connecting rather than separating people. But if we all imagined ourselves situated under John Rawls' original position and behind a veil of ignorance, a TRC to upward structural inequality is what we'd all want to do. Thank you.
Thank you, Dr. Sabatello. Dr. Benjamin.
Hi, everyone. Good morning. As Dr. Sabatello pointed out, health inequities arise by differences in access to healthcare services, differences in the quality of care received within the healthcare sector, individual behavioral differences in the approach to health or healthcare, and differences in the societal, political, economic, or environmental exposures. That includes, of course, racism and other forms of discrimination. In the real world, what that means is that your zip code matters, where you live matters, how you're treated matters. And we know that where you live as place offers a whole range of things that either enhance your ability to get to be healthy, or inhibit your ability to be healthy. I want to focus like a laser, though, on this whole issue of race and racism. And just to remind us all that race is a social construct, which is based on physical characteristics, not really based on genetic or characteristics. And that racism is the false belief, keyword false, belief in the superiority of one group of people over another based on race. And the tragedy around racism is that it obviously unfairly disadvantages the group that has been discriminated against and been targeted. It also favorably and unfavorably advantages the group that feels or acts as though it is superior. But at the end of the day, the whole society is disadvantaged. And I just remind people what would happen if, speaking through the lens of an African-American person, that if we didn't have George Washington Carver, who I think most of us in school learned about all the amazing experiments that he did as an agricultural scientist with the peanut, with soybeans, and many other agricultural experiments that he did, which are benefiting us today. If we didn't have the work of Dr. Charles Drew, many of you know Dr. Drew was a physician scientist who made it our understanding of blood and blood banking, which allowed us, frankly, to save millions of lives, both tragically in war as well as in injury. I mean, without Dr. Drew's science, many, many more people would have exsanguinated. And as an emergency physician, I certainly relish the studies and knowledge base that Dr. Drew brought to the table. Or the three ladies that were highlighted in the movie Hidden Figures, Katherine Johnson and Mary Jackson and Dorothy Vaughan and others, other colleagues that they represented in that movie, which basically helped us get our science program off to the ground, as well as getting us to the moon. And many of the, in fact, most of the efforts that we have benefited from in space travel, and then all the spin-offs in technology that have occurred since then are the direct result of many of their work and assistance in that process. So, maybe someone would have come along and done that stuff, but, who will ever know? But I can tell you that we would not have had the benefit of those people as an example of their amazing work. If you think about people like Dr. Ho, he's a virologist and has been on the forefront of the work that we've done with both HIV and now with COVID and the work that he's done there. And many of the extraordinary scientific discoveries of our members of the Latin American community that have been part of science. So we benefit specifically from the work and well-being of understanding of the whole rainbow of people in our society. I like to remind people that we really think of racism in three ways. Structural racism, which is the societal things and goods and services that people don't necessarily get because based on race. Personally mediated racism, which is the kind of racism that people most think about, that people recoil from. You know, I'm not a racist because I don't hate anyone. And yet we know there are people out there that do, that fundamentally hate one another. We see that in the white supremacist groups. We see that with groups like the Ku Klux Klan. And we're now beginning to see these with these emerging groups in our country that have been so far below the radar screen. People tend to focus on personally mediated racism, which is certainly very prevalent, has now raised its ugly head in our society. But I gotta tell you, it's that structural racism, which is more pernicious, it's more insidious, that we really have to think through from an ethical perspective. Then of course, there's internalized racism, and that is the acceptance of these views of others against people, where they've accepted and they've been told, you know, you can't be a doctor, you can't be a nurse, you're not smart enough to do this, where people actually believe those things and therefore don't really work to achieve their full potential. Now they played out a lot, racism played out, particularly structural racism, in the COVID-19 outbreak, in terms of access to testing. You know, again, I said access is very important. Well, the fact that many of the tests that were initially offered to people, the capacity to get them weren't in the neighborhood. People had to quite frequently go far away in order to get tested. And the way we structured a lot of the early tests, basically the fact that you had to be you had to have symptoms in order to get tested, resulted in huge barriers for people who didn't have access to care, didn't have a car, didn't live close to public transportation. And so testing disproportionately did not benefit us all equally. And then we know that personally mediated racism played out, particularly while wearing a mask. But we had great stories of African-American men who would wear a mask and go into a store and were asked to leave while they did not treat non-Hispanic whites the same way because they were wearing a mask. People, for whatever reason, discriminated against them, whether they were afraid, inappropriately afraid, I might add, of these individuals, or simply decided to target them for one reason or another. Also, there are many of my colleagues early on that would tell us, you know, I'm not so sure I want to wear a mask. And this was in the early days when we did not know the true effectiveness of mask wearing. But even then, people were afraid of being profiled by wearing a mask. And then we now know for sure that also people did not want to get testing because there was always this fear that you would be profiled. If you were found to have COVID, of course, not only could you not work, but people simply did not want to feel threatened by having had COVID. And it was kind of a complex concept for people early on as part of the testing phenomenon. And then, of course, we now know that vaccinations have not been equal by any means. Hesitancy certainly played out a role in the early aspect of the COVID-19 pandemic. But the more pernicious, again, issue here was where the testing was done. The testing sites weren't in the neighborhood. They were not close to individuals. And even though we champion the fact that everyone lives about 5 miles to a pharmacy, access to vaccines have continued to be a challenge. And even 5 miles, if you're elderly or you live off the transportation route, may be very, very difficult to get there to get your shot. So we know that this has continued to be a problem in our community. And I think Dr. Sabatello's paper on COVID and the aspects of the outbreak is a very fine piece of work in many ways that it really clearly explained some of the challenges that we have. And the real problem was we knew these were going to be issues. This is not new. This is stuff we already knew. We've seen this for every new disease that's entered the community. And the failure to act early to address these things, I think, was a fundamental systems issue. And basically, in many ways, built on structural challenges that we could have prevented. Thank you.
Thank you, Dr. Benjamin. Professor Yearby.
Thank you. And I just want to thank you for including me in this. I enjoyed reading the paper and actually wrote a peer commentary and called Reifying Racism in the COVID-19 Pandemic Response about it. I'm going to focus my comments on three particular areas. One, to talk about systemic racism, and in particular, the need to have strong community input. The second one is going to focus on addressing discrimination as part of the truth and reconciliation process. And the third is really to talk about the ways that we can connect the solution to how cities, counties, localities are declaring racism as a public health crisis. So one, in terms of racism, Dr. Benjamin defined structural racism. I'm going to even expand it more by talking about systemic racism, because it really goes to the disempowerment of communities. And so when we think about racism, systemic racism refers to a complex array of social structures, interpersonal interactions, and beliefs by which a dominant group categorizes people into races and uses its dominance to disempower and devalue other groups and differentially allocate societal resources. And as was mentioned before, it doesn't necessarily have to include bad intent. It's often done in neutral terms, but it is really about power, right? And so this builds on the work of David Williams, Nancy Krieger, myself, who's written in this area, but it's really about power and taking away power from communities. And so when we look at COVID-19, what has been crystal clear to me, beyond all of the other things that have been highlighted, is our failure to empower and to listen to community as they try to address this pandemic. If we had listened to them from the beginning, we would have known that they didn't have access to hospitals. And so don't put a majority of your testing and treatment in hospitals. If we had listened to them, we wouldn't have done the same thing around the vaccine allocation. We wouldn't have necessarily partnered with pharmacies. We would have begun by listening to them, empowering them, paying community health workers who are part of the community to lead the charge, especially since we know that's the way that we have been able to overcome barriers in the past. And so to me, it's really clear, if we are going to address racism, then the thing to do is to empower communities to take the lead. And so moving to my second point about talking about truth and reconciliation and discrimination, if we are going to do truth and reconciliation, communities should lead. We always talk about the fact that we need experts from across disciplines, and really what we need is community to lead and decide who they want to be a part of the overall truth and reconciliation. To me, that's the best way to go. And it gets to some of the gaps we've seen in other places in other countries, particularly in South Africa, where they had a truth and reconciliation process, but never ever fully addressed the economic inequality that is still rampant there, right? And so we need to let community begin to decide. There are many people in the community, educated, knowledgeable about the things that they need, about the everyday troubles that they have in terms of catching the bus to go to work, catching the bus to even get healthcare. And so we need to prioritize and empower those needs. We need to do so in a very thoughtful way. Let's not go in and ask them what they need. They've been telling us over and over again. There have been lots of studies that have gone in and asked questions of communities. I know they have done it here in North St. Louis, and we have those reports. So what we need to do is go back to those reports, go through them, then go back to the community who we've asked and ask them what are the top things and priorities they want to move forward right now. How can we support them? How can we build capacity so that after the Truth and Reconciliation process is over, that they continue to have the power and lead the way for change? And so I will get to my third point, which is I think that it is a great idea to start at the federal level. But right now, we see a lot of friction between the federal government and the state governments. And so can we use the declaration of racism as a public health crisis to integrate a lot of these truth and reconciliation processes? And I highlight this because I know a couple of years ago, the Kellogg Foundation was supporting communities and groups to actually begin the truth and reconciliation process. And it seems to have taken hold in some communities as they're declaring racism as a public health crisis. And so we should build upon this. And actually, I, along with my colleagues at the Institute for Healing, Justice, and Equity, wrote a report in September 2020, identifying the cities, counties, localities, declaring racism as a public health. And one of the keys that we said to this process was a truth and reconciliation process. You see some communities beginning to do this, really deciding that they want to form community panels and boards to talk about what has happened and to move forward. But if we are going to build on those processes around declaring racism as a public health, we need to include not just truth and reconciliation, but healing. Because it's not enough just to listen to what has gone on in the past. It's not enough just to begin to provide monetary redress. We also have to heal from that, and all of us do. As was mentioned prior, I think Dr. Benjamin talked about how racism impacts us all and holds us all back. But what we need to do is also be very clear about incorporating a healing process, so that as people are trying to move forward, that they begin to heal, and we begin to train people on trying to address their mental health and well-being, along with the physical ramifications of experiencing racism that we have all had to deal with. And so with that, I will stop, and then I look forward to more questions. Thank you.
Thank you, Professor Yearby. Thank you all for your wonderful presentations, and we'll now start taking questions. If you have a question, please put it in the Q&A section. And I have a few questions here prepared by my AJOB colleague, John, that I'd like to start off with. First one here is about disparities. And the disparities that we've seen during the pandemic are similar to those that have existed long before the current pandemic. The question is, did we learn anything new during this pandemic about health disparities that we didn't know before?
All right, well, let me start by just saying that I think what we did learn is how effective in terms of capitalizing on those inequities a very highly lethal, highly transmissible virus can be. I think everyone kind of expected to have some inequities, but I don't think anybody expected the magnitude of what we saw. I think that, we've seen, in opioid epidemic and the obesity epidemic, but those are relatively slow growing epidemics. I think this one it went through like a flash fire. And all of the things that could go wrong with inequities that were magnified by those inequities, from mistrust to the initial belief that false belief, by the way, that it didn't impact minorities, particularly African Americans at all. Of course, that was by no means true, and it could not possibly have been true. To the societal issues, to the politicization of this event. And I just think it was all those forces came together just to make it a much larger issue than I think any of us could have imagined.
Yeah, I want to, retire some of it. I really do appreciate Dr. Benjamin's comment here. I think a lot of the data about health disparities were known. We chose not to look at them. What the pandemic brought to the fore is how everything intersects and interacts. And, you create bombs by small pieces. But when you bring all the health disparities and all the discrimination in different aspects of life together and you put it in one pot, that's where the explosion happens. And that's what we've seen here. So I don't think that the separate findings about health disparity, for example, in the context of African-American women and childbirth, which has been discussed all over the place before, we know about that. But here we had so many other things that we learned about and we knew about before. They just came together to remind us we cannot address one aspect of life and assume that that will be enough. We have to think about everything in a much more systemic way, in a way that really takes into the human experience of who we are, how we live, how different aspects of life impact our health and our health outcomes. And the whole idea that you cannot access to testing and to vaccines and so forth because you live slightly further away, the fact that the services are not provided in a community place by trusted individuals. I will add that they're very often inaccessible to the elderly, to people with disabilities, and so forth. These are the things that when they come together, that's where it exploded. And I think here, this is what happened. It's not the small details that we didn't know or that we knew we should have known, but the fact that they came together, and that was why didn't we do anything before?
And I'll jump in. I would say, quite honestly, I don't think that we learned anything new. Hopefully, we started paying attention, right? So during the 2009 H1N1 pandemic, researchers before the pandemic and after the pandemic actually highlighted all of these issues. And so we didn't do anything about it. In 2011, 2012, the U.S. Department of Health and Human Services actually issued a report highlighting the need to work with community long-term to address pandemics and to address emergency situations, to address some structural issues like paid sick leave. We didn't do anything about it. And so what I'm hoping, though, at this pandemic, because so many people have highlighted this issue, that we begin to move forward and not just wait to the next pandemic. I would also say what I hope we have learned is that we need to speak differently about these issues. And so initially, when the rates of disparities were seen in Native American communities and Latino communities and Black communities, there was a lot of blaming of these communities by lots of leaders, by lots of people in public health, and talking very differently than other communities. And it continues even when we talk about the vaccines. And so what I hope we learn as individuals working in this space is that there is nobody to blame but our structures and ourselves, and the need to change those structures and give support to the communities who are suffering the most.
And maybe I could add that, these are not inevitable. I think the Navajo Nation has showed us with attention and detail and focus, you can address these inequities. But it requires, good communication, engaging community with trusted messengers, and real focus.
Thank you. So I'm going to link these two questions because I think one addresses structural systemic issues and the other one is more about individuals. So which policy proposals would have the biggest impact on health disparities, such as universal health care coverage, expansion of community health centers, raising the minimum wage, and so forth? And then what can individuals do to reduce health disparities and address systemic racism?
Go ahead, Dr. Benjamin.
That's an easy one, so go ahead, and whoever wants to tackle either or both.
Thanks. So, I think all of these policies are important. They're interacting with one another. And I frankly have no idea why we're insisting that only about $15 an hour. If you look into the history of inflation and changes in living expenses, we know that the $15 from 30 years ago, for example, when the federal government last updated its salaries, it should be now 20. So even 15 for me is like, why are we chipping out on other people's work, and rather than provide them the means to do that? And I think all of these issues are extremely important. Community health centers, this is where the communities are trusting the people. It's not a secret. Why aren't we doing that more? Of course, that should be an area. And paid sick. I mean, we know how many folks arrived sick to work because they cannot afford a day off. We know that people are refusing now to get vaccines because they say, what if I have side effects and my days are off? I'm already out of my days. So they might be required or strongly recommended to be vaccinated. But if they take the vaccine and they have the side effects, they don't have days off for that. That doesn't make sense to me. But I will also say that, we have to think broader. And I will also say, of course, universal healthcare is a no-brainer. I'm trying to even think, you come to, when you travel to the UK, for example, to Scandinavian countries, you immediately feel that there's a burden off your shoulders. Because you know that if something happens to you, you're not going to be billed with $1 million at the end of it. The stress that comes with having no access to care, and I will say that also people who have health insurance in this country have the fear of paying extraordinary amounts for healthcare. This is something that we really have to change, and I think for me that's definitely a priority. But beyond that, if I'm thinking about the broader long term, I think we have to focus on kids' education. Social justice from day one, history corrected. Columbus came to the United States and found nothing. There are entire communities who were here. How can he just come to an empty land? We've got to be starting to have those conversations with young kids, talking about the slavery, thinking about putting themselves in that place, understanding the role of privilege, understanding the other, learning to empathize with the other, learning to rethink about the facts. And when you go with kids, and I have to say, I've learned a great deal from my kids myself, because this is how you learn. They learn differently. And when you put them together and they interact with other kids and they learn to empathize and to understand the history in different lens, they will grow up to be adults who are more willing to think about their power, to think about what is not right, to become upstanders. When you see it in the medical profession, and we had several articles coming out during the last few months about clinicians of color saying, I was mistreated by my patient, and the senior physician next to me said nothing. And I'm thinking, how is that possible? This is where you start educating kids from age 0. You've got to speak up. You've got to be an ally. You've got to learn the history. You've got to understand that you happen to be born with a certain skin color. It doesn't give you the privilege. You have to make society equitable for all. And I think this is where it starts, and this is where I hope we're going to go.
Yeah, let me add, the golden rule.
Any other thoughts?
It remains, right? It's real, and we've got to really think about how we build a new social compact in our country. We've gotten off track. We have people that do the dumbest things and think that it's okay. They say some really stupid things, and these are people who our kids look up to because they have titles, and they're allowed to do that. They're allowed to do that. They're allowed to be overtly racist and pretend like it isn't. They're allowed to behave in desperate manners towards people. They're allowed to ignore the facts. And we could assume that they know. I mean, one might assume that they just don't know the facts, but history has showed us that they absolutely do know the truth. They just view that it's okay. And I got to tell you, it's not okay. It's not okay for political reasons for you to behave one way versus another. That is not right. And we've got to begin to hold people accountable. And there are tools for us to do that. It's called voting. It's called speaking out. It's called protesting. It's called taking our dollars and, and spending them where, as a way of our, our protests and our voices should matter. And it's a way about not tolerating when somebody says something that is not true is true. And we as a society have to come back together with a collective voice and do more of that kind of one-on-one thing. And it starts, as Maya said, very early in making sure that children are giving textbooks that don't talk about the war of Northern aggression, that slavery was an economic debate, that people are fundamentally different based on race, that this is a nation where everybody made it who made it because they picked themselves up from their bootstraps. No. That's not how the world worked. And that's not how it works then in the past. That's not how the world works today. We need to be more thoughtful and more transparent about these communications with people. And then if we do that in a way that hopefully the idealistic society that we've always hoped this nation would be, then I think we'll be much more successful. But it's got to start by every one of us every day getting up and doing what's right. And we know what's right. We just don't all do it.
So there's a lot of questions coming in. So let's go ahead and start addressing some of these questions. And I think Professor Yearby was typing a response, so I'm going to start with this one. Someone asked about economic inequalities related to lack of education. Sir Angus Deaton and Ann Casey have identified that the BA is now the leading indicator of poor health. Instead of looking at the health systems, I'm sorry,
I was typing the answer to that one. So if I could jump in
and
go ahead.
Do that.
Sorry,
I didn't. It jumped off my screen.
Okay.
Yeah.
Yes.
So yeah. Oh, it's an answered question. I see.
Yes. So the question was about educational
making it more accessible to everyone. She says she's a master's prepared nurse. She's $200,000 in debt for nursing school. Education is one of the greatest places of structural racism as our most higher education institution. So curious about your responses to that. And maybe Professor Yearby, you can start off with that one.
And so what I was typing in is that it is important in terms of economic inequalities, but two key points. One, education is important, but does not fully address some of the income inequality we see for women and women of color, who are often more educated than their male counterparts, but still paid less, or required to work more, or linked to low-wage jobs because they don't have the connections, right? And this goes back to what Dr. Benjamin was saying in terms of you don't necessarily get jobs based just on your ability. Sometimes it's who you know, and we don't see equal sort of support for that. Two, I would say, and this goes back to the other question, is that part of our economic inequalities is about who keeps the money. And so during the COVID-19 pandemic, we've seen lots of businesses who did not protect their workers have record profits and not share it either with their workers directly or implement policies to actually protect them from getting COVID-19. So we see this in some hospitals, Amazon, meat and poultry processing. And so that's part of the economic inequalities too, is that even if you get a job, even if you do the work that you're supposed to do, is that money cannot just stay with people at the top and the shareholders, that we need to do a better job of making sure that the people doing the work actually get the money too.
I'll just jump in also kind of to add on that, because, the money does stay at the top, but the reality is that the return on the money that one makes at some point loses its power. That is, if you're a billionaire and you're making $100 million, the first $100 million allow you to live whatever lifestyle you want. Over that, you really don't get anything from it that much. And at the same time, your money came from the work of others. your money is inherently connected with a society. And therefore, the idea that you're not giving back, and it doesn't have to be, I don't want it to be charity. People it's not a matter of charity. People work hard for the jobs. They need to have the opportunities to make a dignified wage that allows them to have all the opportunities that everyone else has. And so, or so that others have. And so I think, again, even in terms of education, our education system is impossible. It's segregated, and it is expensive, and it's impossible to have the high education that many of us want if you do not have, I mean, again, it's the generational wealth. Think about the prioritization into some top universities. If historically African Americans and indigenous populations and others were unable to get into the schools, their parents have not been members of these schools. They don't get that priority when they now try to apply. And so again, it builds itself. And I think we have to rethink those prioritization. We have to rethink how our educational system is geared or not geared towards real inclusion. And again, it's not a charity based, and that will impact, again, also employment opportunities, and then some changes in how we think about wages, fair wages, and who's the one who keeps the money. Yeah.
So there's several more questions. This one asks, I'd like to understand fully about the logic that shows why we should characterize the COVID-19 pandemic as an example of systemic racism and not simply as poverty-based inequalities. And then the person goes on to say that some racial minorities do not have a solid community tied together by race or ethnicity. How can TRC take up the voices from such individuals who are treated in a discriminatory way, but do not feel that they belong to a specific or particular racial community?
So I think it's important to not confound race and poverty. They may be occurring, but we need to be real clear about that. Because if you are a bus driver or a plumber, if you are a manager in a grocery store, you may very well have an amazingly good income coming in. Particularly if you're a public employee who's more senior. I think the issue here, though, is that you have to go to work every day. And therefore, you're more likely to be exposed in a disease that you get from other people if you have to go to work every day and you're out in public. Now, if on the other hand, you are also have high blood pressure, or you're a little overweight, or you have a heart condition, and you get COVID, you're much more likely to be disproportionately sicker or die sooner because of those chronic diseases. So let's pick one of those chronic diseases out of that list I just gave you, called hypertension. So we know that hypertension is modulated by the endocrine system. And I don't care if you are a MD, PhD researcher who happens to be African American, or you are a maid or a janitor, or you're a bus driver, pick the income level for any of those people. Your hypertension is partially modulated by how much mess and stress you get every day. And so when you walk out that house, whether or not you're wearing a uniform from the bus company, or you're wearing a suit and tie, if you're more likely to be stopped on the street or threatened or feel threatened by folks because of your color, or if you happen to go shopping and people watch you as you walk around the room, because we know when they're doing it, you're much more likely to be more stressed and have a higher blood pressure. We know very specifically with COVID that both the organism as well as the targeted receptor of that organism in your body is a targeted receptor for a high blood pressure. So there's not only a psychological basis for you having challenges, but there's also a biological basis with your high blood pressure for you being more at risk. And so we have to make sure that we understand the complexities of all these issues. And so race, chronic disease like high blood pressure, more susceptibility to COVID, there's a timeline there you can connect the dots. Not necessarily due to poverty. Now, if you happen to also be in a job where you don't make as much money, then you're also much more likely to be in a smaller home, that if you get infected, you're much more likely to bring that home with you. So why do you live in that home and why do you live there? Well, there's a whole history of redlining, which, historically put people of color in smaller houses, in certain communities, with greater economic stress. Again, stress, high blood pressure, stress, more obesity. So we can connect the dots, again, psychologically, as well as physiologically, to race, to racism, and to the conditions under which, should you get exposed to a disease like COVID, you're much more likely to get sicker and die sooner. And then you add on the fact that testing was limited in the communities of color, that clinical access to care was limited to communities of color, and that vaccinations have been structurally limited to communities of color. You get a much bigger picture of this connection. It's not because somebody in the hood said, I'm gonna make sure these people didn't get it. No. People with privilege designed a system that benefited them and disadvantaged others.
Let's take this question. Pandemic perpetuated narratives, as Dr. Yearby was saying earlier, is bringing forth African-American, quote unquote, hesitancy, which is characterized as mistrust of the medical system and personal health behaviors, instead of looking at the health system's trust of traditionally marginalized communities and issues of access to vaccines. In contrast, white, quote unquote, hesitancy was framed as personal freedom. Any responses to that?
I agree. I think that is a very interesting comment because it's been throughout the pandemic, right? In terms of blaming, in terms of lack of autonomy, in terms of discussions of we just need to educate people, that it has been very racialized. And so again, I think we need to, instead of going from we know what's happening, so we're just going to educate our way out of it, instead going to community and asking, what are the issues? I think Dr. Benjamin and Dr. Sabatello have already highlighted this, right? It's not just where we are now, it's where we have been, right? And so it's the mistrust that has built up over years and even over the last year of looking at how they have not been supported, right? These groups have not been supported. When you think about the Native Americans, they couldn't even necessarily get the testing results from the states or from the federal government about who was impacted. And so then you shift to say, oh, now you need to take this vaccine. So I think it's very clear on the differences in our language. And I'll just say at the end, what it does though, is that it means that we don't focus on particular groups, right? So we try to educate Black people about the safety of the vaccines, and then we leave white people alone and just say it's their personal freedom, instead of saying to everyone, here's what the vaccine's about, here's how we can support you, here is how it can get you back to the life that you want to get to.
Any other responses to that before we move on?
Yeah, let me just say that, remind everyone that it's okay for people to be curious about vaccines. When I was practicing clinical medicine, then I would always try to explain to anyone about any medication that I was giving them. Vaccines is another therapeutic, another medication. We know that we, due to the modern science, we're able to produce this vaccine very, very quickly. There's no question about that. But we understood why we were able to do it. It was just not adequately articulated early as to how quickly. And it got hung up in the politics of the whole response as well. I think the challenge we had was that we spent a lot of time, effort, and money doing research on vaccine hesitancy, and then not enough time, as Dr. Yearby points out, articulating in appropriate ways to communities based on what we already know, how people see their concerns about the vaccines. And I think that requires some effort. Now, a lot of work has been done trying to understand how to effectively communicate. You have to communicate to people where they are. It's not just the message, it's the messenger. You know, I try to influence influencers because I'm pretty clear that Mrs. Jones down the street doesn't know me and is less likely to trust me because she doesn't know me. But she does know her doctor, she does know her nurse. If she has a interaction with the medical community. But I can tell you who she does know. She knows her pastor. She knows her barber, her beautician. She knows her cousin. And if we can influence those people with the right information, then they're not likely to get mixed messages from people in the community. And we know, by the way, there are groups that are purposely targeting communities to create mistrust. Some of them come from out of this country, some of the people that are doing this, and some of those people that are giving the mixed messages and the wrong information are people in this community and, or in this country. And so we need to recognize that their motives are not pure. So when you see a flyer that was passed out disproportionately in communities of color, which said, if you get COVID, then you should get on the bus and go around into other communities, i.e. trying to get other people infected. Or you should not take the test because what they're trying to do is they're trying to get your DNA. They're really drawing your blood for DNA or swabbing your throat so they can put you in a registry. That builds on people's fears. And there were people that purposely did that as a way of creating mistrust at the very least. And there may be some other nefarious reasons for doing it as well. But we know that purposely happened in our community, and at least African-American community for sure. We know that the Latin American community, disproportionately working in meat packing plants, were often told, no, they didn't get infected in my plant. They must have got that in the community, right? They got infected in the community. No, they didn't get infected in the community. They got infected in the plant. The epidemiology said that. The health department said that. And yet they were allowed to lie and say their plants was not where people got infected. Maybe it was for liability reasons. They were trying to cover their tails. I don't know. But that's not what happened. And we should have allowed that to happen. We should have, many of us did speak out, but it should have been more of that speaking out. And the administration at the federal level should have spoke out, and they should have required them by law to protect those workers. Because what happened was those people in those plants got infected, and somehow, this is the racism part, they're somehow going to be protected because it's only occurring in those people. And yet, those people live in your community. Any reason not to think that everybody else is not going to get infected? No, they use racism to stigmatize that population as being infected and believed that they would not be infected because it was only in those folks.
I also just want to add, the whole framing of vaccine has been as a personal choice only almost, and then of course of communities of colors that they don't have trust. But in fact, it should also be framed as a solidarity issue. We're one nation in an effort to go back to normal times. And if you're not vaccinated, if you don't take care of yourself, you might be hurting not only your friends and families, but actually the larger community, as well as more vulnerable folks who cannot be vaccinated. And so there is some solidarity that we have to remind ourselves. This is a nation that's the idea behind nations. nations are built on some sort of solidarity. That's from the philosophical perspective. If we're not even doing that, and we're not offering security, then what are we doing? And so I think we have to also rethink about it in that context.
So I think we have time for at least a few more questions. This is a question that I can imagine my medical students asking. And this question goes to the challenge for medical practitioners is how to ethically treat patients as you find them in a healthcare system that is structurally unethical. How can we best address this issue?
I just started to respond that and then stopped in the middle because I think there's so many questions. There are a few things. I think one is, I think medical institutions have to start awarding clinicians differently. Speaking up is a plus, is not a minus. And even when you have a system, we're seeing it across areas of medicine, not just in clinical care, but also in research. And you see things that are, when things are wrong. I think we all have responsibility, not just clinicians, because again, they are a part of the system, but we all have a responsibility to stand up and say, this is unjust. And even if it is within our system, we have to make the changes and to push for it. Institutions are hard to change. And they're not happy to make changes, especially if that means a little bit less money in their pockets. But we have an obligation to do that. And I think this is actually maybe a time that medical schools and institutions and systems are more willing to at least consider some of these issues. At least I'm hoping that this is where we are. And so I think, I think we need to have that conversation across the board, across areas within medical systems, within medical institutions, and try to find alternatives. But I do hope we're going to end up with some universal healthcare system at the end of the day. So that will hopefully help with some aspects of this.
Any other responses to that before we move on? So a couple more questions before we wrap up. There's a growing discussion of Black bioethics. How is the field responding? Students increasingly express anger that the scholars bioethics relies upon are white men writing from countries which are post-colonial powers. The field has talked about this for years. What can be done in the here and now?
Yeah, well, I think the need for diversity is really coming very strong now. We have seen that in the context of disability studies, for sure. We're going to have more of that in the context of disability studies. COVID-19 has long haulers, and we're going to have more and more people with disabilities. That means that if we previously had a disproportionately high number of people with disabilities within racial and ethnic communities, they're going to have more now because of COVID-19. So the voices of those communities are critical. They are so critical. And I can only repeat Dr. Yearby, we've got to listen to the communities. We've got to listen to what they need, what can we do better, and what would work for them. And I think we have to understand, there's no one voice for anything. That's a part of the beauty of life. So we've got to be open-minded about it. We have a tendency of thinking everything through our own windows, and this is how we're brought up. We all have our baggages, we have our values, our systems, our reflection on our family story and other things. But we have to be open enough to hear others, and this is a critical moment to do that. So, yeah.
Let me add that, look, we all carry biases with us each and every day. They're based on lack of experience, lack of knowledge. I've always lived in an integrated environment, so I've always seen people across races through my whole life. But there are people who do not. There are people whose life experience of other races consists on what they see on TV and whatever stereotype that they see on television or maybe the radio, assuming they watch those particular shows. And tragically, we continue to live in our own ecosystem. We watch only the news shows that give our own, views of the world. that align with how we think today. We commonly work in communities where we don't necessarily have diverse views. And so people's view of the world is reinforced quite often by what they see. I remember that we also have communities where particularly young people may not have broad experiences beyond the communities in which they live. When I was the health commissioner in Washington, D.C., I often tell a story of kids that were going to go on a trip to Britain. And I was excited for those kids because of all the wonderful things I knew they would see once they get to Britain. And I was admonished by the head of the Human Services Committee. We were having a conversation about these kids' trip. And he said to me that these are kids that lived over in Ward 7 and 8 in Washington, D.C. And those were the more impoverished part of town. And his point to me was these kids were not excited about going to Britain, at least not yet. Their excitement was going to National Airport because their universe and their world where they lived, if you ever go over in Ward 8 in Washington, D.C., you see the planes come over the horizon from the airport, but these kids never had seen where they came from. So their world and universe was the ward in which they lived in. And an occasional trip downtown to the city hall and then back. And that was their universe. Now, those kids, as I understand, had a wonderful trip once they got to Britain, but all they could think about airport. By the way, the airport in the Washington, D.C. region is within a community of 10 square miles. And then, of course, this is one ward in the city. So their universe is very, very small. And far too often we have kids who don't believe they're going to live beyond their 15th or 16th birthday because they don't know too many people that have lived beyond their 15th and 16th birthday. And we have people that in Appalachia and other parts of the community and rural communities who have never, ever seen a person of color. So we got to recognize that we've got a lot of work to do to give people the life experiences that undermine those biases that we all carry and that get reinforced through life. But it does take work. This doesn't happen by chance. It works because people want to resolve those issues. Have people talking to one another so they can hear each other's views, but recognizing that those biases, they don't go away easy, and we all have them.
So that's a good segue to our final question, and this question I think kind of reflects the response of I'm sick and tired of being sick and tired. This person says, I'm an older African-American woman and have severe racism fatigue. Everything that's being said in this webinar by this excellent panel of professionals has all been said before. It seems that each generation of African-Americans is having to address the same issues, health disparities, wealth disparities. Nothing seems to change structurally. How do we move forward? Is this a failing of the educational system? How do we change general educational and medical education? Perhaps, Professor Yearby, you can kind of talk a little bit more about the healing aspect, because we talked about truth and reconciliation. That's just the start. I mean, we're really trying to heal a broken system, and maybe you could speak to that, please.
So I would say we definitely need to heal a broken system. I think where we are really picking up after the civil rights movement of continuing to push forward and continuing to push forward with community and community taking the lead. So we see the Black Lives Matter, the Occupy movement really pushing people to think about income equality. And so I think people are healing. When you look at the declarations of racism as being a public health crisis, it is trying to heal, right? So even when you look at, I want to say, in Illinois, where you are, right? And deciding to move forward with reparations because they have specifically linked it to redlining, and that this is a way to begin to talk about it and to heal from it. And so I think more needs to be done, right? Because as we talk about these processes, we do not give people an opportunity to voice, to write, to grieve what they have lost. And to me, that needs to be a part of it. And that's what we have sort of talked about in our report. But I think for me, we are beginning to move forward. And so we just need to continue to push the communities to move forward. When they say racism is a public health crisis, what does that mean? How are you going to change? In Boston, they actually decided to shift some money from policing to support people to get housing. In Connecticut, they're talking about trying to support people in terms of a fund to give to kids. And so those are the things that we need to do. But we need to talk about how can we heal them and what practices are going to be a part of it. And I think, Dr. Benjamin, you also mentioned this when we were talking about companies not wanting to admit that their workers have gotten sick. Part of healing is not to say, we're going to sue you. I think people think about that, but part of healing is to be able to talk about it and move forward. And people aren't open to that because they're not open to actually acknowledging that they've done some harm. But I think if we come to it saying that we have all been harmed and these are the ways that we're going to move forward to change, then that's how we get to the place that we need to go. Sorry.
And I just want to also say it is a process and we've got to embrace that process. You know, there's no shortcuts. It's not going to be from today to tomorrow. I think communities are really harmed and hurt. We have to give the time and take the time and help provide the supports that are needed for that purpose. So.
I think we will leave it there. I wanted to thank our panelists, Ruqaiijah Yearby, Maya Sabatello, Georges Benjamin, for all of your insights today. I thought this was a very rich and important discussion. I want to thank all of our attendees for their questions and comments. Thank you all. This is being recorded and this will be placed on AJOB's YouTube page. Thanks, everyone.
Thank you.
Bye-bye.
Bye-bye.